Good evening. I'm Dr. Jeffrey Spear, current president of the El Paso County Medical Society for 2022. We at the El Paso County Medical Society are very proud of this program. We are certainly grateful for the collaboration of both Star City Studios and KCOS for making this program a reality. We're also incredibly grateful to Ms. Catherine Berg, who has been such a terrific partner for the last 25 years being this program's host. We hope you continue to join us each and every month for this fantastic program, and please enjoy the presentation tonight. Thank you very much.
There's much optimism when it comes to prostate cancer these days. There's new research both currently going on and on the horizon. During the next hour, we have experts answering questions about prostate cancer, everything from screening to diagnosis to treatments. This evening's program is underwritten by Rio Grande Urology and Rio Grande Cancer Specialists. And also a big thank you to the El Paso County Medical Society for bringing the show to you for over 25 years now. I'm Catherine Berg, and you're watching the El Paso Physician. Hello, I'm Catherine Berg, and you're watching the El Paso Physician, and tonight we're talking about prostate cancer diagnosis, treatment, and new advanced care options. And with me tonight are, I consider them two friends now, which is really nice. Dr. Vogelweed, who has been around, and we've been doing shows together for about, I think, 25 years. I think you were one of the very first guys on the show. Prostate cancer, testicular cancer, we talked about all of that stuff way back in the day. And then we have a young one with us. We have Travis Mendel, but there is some history with your family and genetics, which we're going to get into in a little while too. But Dr. Vogelweed is a urologist specializing in cancer. And then we also have Dr. Mendel, who is a radiation oncologist specializing in this area as well. So what I'd like to do, Dr. Vogelweed, is start with you. And if you can explain to our audience what your specialty is and kind of migrating into the care that you do with patients today. So urology, yes, but you do a lot in the cancer space.
Well, right now, I pretty exclusively just do advanced prostate cancer.
Okay.
I no longer do general urology. And basically, the patients I treat are patients that have been treated primarily for prostate cancer, and the disease comes back. They either have radiation therapy or they have radical surgery. And after that, their PSA is supposed to go down to a very low level. And if it starts rising again, then the cancer comes back. So that becomes advanced prostate cancer. And of course, there are patients that show up in the hospital or in the office and they already have advanced disease. But that's basically what I take care of.
Okay. And then Dr. Mendel, when we're looking at radiation oncology, so I can ask you about the chemotherapies, if that's the case. I know with prostate cancer, it seems to be less chemotherapy, more radiation. At least it's how I remember it from the old days in your radiation oncology. So if we could kind of take that same question and explain what your specialty is.
So basically, we use radiation to treat solid tumors. We target the tumors or several tumors. If there's metastatic disease or anything like that, we target the tumors. And so I tell the patients we're either going to cure them if they're going for definitive treatment, or if they're palliative, meaning there's bone metastasis or this cancer has spread other places. I tell them that we're basically going to be spot welding.
Spot welding. Yeah. I like that. Yes, very, very targeted. And I like that too with prostate cancer. I feel like over the years, there have been so many advances in how tumors are treated specifically. Dr. Vogelweed, and I know this seems oversimplistic, but for some who don't know exactly where the prostate is, can you describe in the anatomy, physiologically, where the prostate lies? And in that, I want to almost directly go into screenings. Because we have the blood test, the PSA test, we have digital rectal exam, and I think the idea of where the placement of the prostate is and what the digital rectal exam is, that helps people kind of understand those two.
Can you imagine having a party for one of your kids? And one of the things that's essential for a party is a balloon.
Mm-hmm.
Okay. Mm-hmm. If you can imagine the balloon and then the neck of the balloon. Okay. Which is where you inflate the balloon through. Well, the balloon is the bladder. And the long tube is the urethra. Mm-hmm. Well, the prostate sits on the urethra right at the bladder.
Okay.
Mm-hmm. And the reason why you can feel the prostate with a digital rectal exam is that when you do stick your finger up the rectum. I
Mm-hmm.
could use another word, but I won't.
I know, but you can. It's PBS.
yeah.
Anything's allowed, I think.
Well, I think rectum is a little bit more
As long as
appropriate.
it's educational.
Yeah.
Yeah.
You can actually feel the backside of the prostate.
Mm-hmm.
And if there are any changes in it, you can feel size to some extent, and you can feel consistency. And if you have a change in consistency, particularly if it's hard or there's a hard nodule, then that's suggestive of prostate cancer.
Mm-hmm. Mm-hmm. And then when we're talking about screenings again too, in combination with a digital rectal exam is usually a PSA test, which stands for prostatic specific antigen. Is that correct?
Prostate specific antigen, yes.
Okay.
One of the big misconceptions is that if you have a PSA below 4, it's normal
Mm-hmm.
and you don't have to worry about it. That's really not true. You can have a PSA of 1.5 and have cancer.
Mm-hmm.
There is there's an age difference. Okay, it's not the same thing to have a PSA of 3 when you're 70 as to have a PSA of 3 when you're 50.
Exactly.
Okay.
Right. Yeah.
To me, the rule of thumb is if you're from the age of 40 on, if you have a history of prostate cancer in your family, or if you're Ashkenazi Jewish, or if you're Black, then you have an increased risk, and you should probably be screening from the age of 40. Normally, I suggest screening at the age of 50. You only have to do it once.
Mm-hmm.
If you screen and their PSA is less than 1.5, and certainly if it's less than 1, you probably don't have to check it again for 5 years.
Okay.
Okay.
Yeah.
Number 2, if you have an elevated PSA, that doesn't mean that you have cancer.
Right.
Okay. And there are some tests that you can do nowadays that will help you with that screening and help you decide. One of them is to do an MRI of the prostate. The MRIs up to a certain point can identify a focus of cancer. The other is genomic testing, or you can actually test the urine or you can test the blood, and it can tell you whether or not you're at an increased risk of having cancer. Then you can make a decision on to whether or not biopsy that prostate to see whether they do have cancer or not.
You hit on something that I'd like to talk about. I'm not quite sure where in the show I'd like to do that, but I would love to talk a little bit about genetic testing. But I would like to talk about, you hit on some risk factors, but then also family history. Black individuals, Ashkenazi Jew individuals, yes, but then also if mom can't have prostate cancer, but if dad, uncles, brothers, etc.
Immediate family.
The immediate family. So where is the danger there?
Well, the danger is, even if you don't have genetic disease, this is going to become more complicated, but even if you don't have genetic disease, if your father or your brother or your immediate uncle has had prostate cancer, you are at increased risk.
Mm-hmm.
If you have inheritable disease, it could be that your aunt has breast cancer, or your father had pancreatic cancer, or your grandfather or grandmother had ovarian cancer.
Mm-hmm.
All of these, if they carry a specific genetic abnormality, and there are several, okay, then they can be at increased risk, and they should probably be tested. It's a simple blood test.
I'm in full agreement. And Dr. Mendel, I feel like I'm throwing you under the bus because I didn't talk about this prior to the program, but I'd love to talk a little bit more about that. So I said breast cancer, but there are certain cancers of the reproductive organs that are not, the genes aren't shared by the men and women, but the tests that are kind of pointing to them are. If this is not something you're versed in, tell me. It's like, let's not talk about genetics tonight, but I always feel like that's fascinating. When you can, like BRCA gene, you can get tested for BRCA genes, and there's now like a slew of other things you can be tested for, and feel free to hop in too, because I know we started this. But what is it that, and I'll start this too, it's a simple blood test. Insurances will cover if there is family history, but maybe not. But if there's something you're worried about, again, it's the blood test. And I'm asking either one of you. And Dr. Vogelweed's kind of doing the stutter start.
Yeah. So, I mean, I think most patients can get genetic testing.
Okay.
And in your insurance will pay for it if you have some sort of family history.
Okay.
Most patients that come to my clinic, they have a cancer diagnosis. And so that already kind of puts them to the front of the line for these type of testing. And the guidelines for these testings are always changing. And so there's a The NCCN is kind of a guideline that most oncologists use to manage cancer patients. And so each disease site has a specific guideline for genetic testing. So there's two different types of testing. There's genetic and genomic. So it's what your genes are, or what does the cancer actually have? Because the cancer, it mutates its genes, and that's how it grows.
Right.
So the genetic testing, which is what you're talking about,
right,
is very prevalent in actually other disease sites as well outside of the prostate. And we're becoming, it's becoming more in vogue, I think, for prostate cancer.
Yeah.
So, but two things I should mention. Yeah, they have it for ovarian, they have it for pancreatic, they have it for breast, they have it for colon, but genetic testing is not 23andMe.
Exactly.
Okay.
Expand on that. Thank you very much. Expand on that, because it's very specific. Blood tests and testing for medical issues, not just, hey.
Yeah, the genetic testing is specific for specific genes. I'm sort of repetitious here, but and that's what you're testing for, because there are certain genes, and they're not the same ones for gastrointestinal cancer as they are for prostate cancer. There are some genes in prostate and breast and pancreatic and ovarian that overlap with the BRCAs, BRCA1, BRCA2, ATM are some of the more common ones. GI has something that's called the Lynch syndrome. And Lynch syndrome is associated with prostate cancer. It's associated with, I think, uterine cancer and colon cancer, and I think even brain cancer. So don't quote me on that. I'm not.
No. That's what the disclaimer at the beginning of the show is for.
Yeah.
Cancer cells, they have specific genes. There's genes called oncogenes, and there's genes called tumor suppressor genes. And so that's why there's so much overlap between different cancers, because your cells just inherently use these genes to protect themselves from becoming cancerous. So your body's always, like, your cells, they sometimes become haywire, and your immune system is able to either eat them, or the cell self-destructs because it knows that something's wrong. But when you lose that ability to either detect the cell with your immune system, or your cell is not able to detect that there's a problem, that's when you get cancer. And that's why there's so much overlap between different cancers and the genes. And that's why when patients have an inherited gene that puts them at higher risk, that means they're more predisposed to developing cancer, number one, like the BRCA gene. We know this for breast cancer.
Right.
But also they become higher risk with just cancer in general. So if they develop a cancer, they're higher risk for having metastatic disease or higher grade cancer than a person that doesn't have this mutation. And so that's why it's become so important in the prostate cancer land, because we have, the way that we've studied prostate cancer hasn't changed that much from like the 70s. So patients, they have an elevated PSA.
Right.
They go get a biopsy.
Right.
The pathologist looks at it with their eyes. Okay. If they're looking at it and it's, they just kind of give you their opinion. Right. Everywhere else, all the other fields, they're moving to more of like molecular testing that's more objective, where you have a real, not a person's opinion. You have genes, you have, RNA, DNA, they analyze everything with, microarray analysis to see what mutations those cancers have and how they are more aggressive than this cancer completely objectively. A computer does it. So these genes now patients, we know which patients are higher risk than the normal population. So it turns into, this patient has prostate cancer. Do you feel comfortable watching this patient because they have an inherited mutation that makes them higher risk than just what you see with your eyes? So it kind of completely changes the ball game. So it's a fascinating time right now in prostate cancer, because it's evolving so rapidly. There's new things, but it's funny because this is all happening in all the other disease sites. So like for brain tumors, it's now basically all staged genetically. They look at the mutations in the tumor, and that's kind of what determines the actual WHO grade of the brain tumor.
Okay.
And I think that's where a lot of the fields are now moving towards, is this more objective data that, instead of people telling you like, oh, this looks scary, this looks bad.
Right.
We're going to give it a 4.
Yes.
Right. Or this one looks okay.
Now there's something specific that points to that.
Exactly. They won't give it a 1. They'll look at the genes, and now it's going to be, oh, this is high risk.
Right.
Does that make sense?
It does make sense. And I like too that you split it out between there's genetic and then genomic. And so genomic is at looking at what is currently existing in the cancer that you have, and then being able to, I'm going to just try to put it in layman's terms, trying to be able to stage that, for the lack of a better word, and then look at what treatment that's going to be. And you're right, the stages is always like, well, you go to 2 different doctors and that's stage 4. Well, maybe it's stage 3, depending on metastasis, et cetera. And again, it's different with all cancers, which to me is always fascinating. My question is to the general audience member, and again, because everybody hears genetic, when there is testing genetic, not 23andMe, but specific genetic testing, the paranoia that may or may not come from the results of that. And I'd like to talk about that a little bit, because we don't want everybody running out and demanding genetic testing on specific genes. But if there is a higher chance in your family or you're in certain risk factors, that might be a good idea to do. And Dr. Vogelweed, if you can just kind of play with that thought of maybe after the show, someone's going to say tomorrow, they're going to see you at the grocery store and say, hey, should I go get, my genes tested? And now they're asking you because we talked about it. How would you like to explain that to the audience?
Number one, the first thing is, just because if you have breast cancer, okay, your daughters don't have a 100% chance of developing it.
Right.
Okay. They have a 50-50 chance because they may or may not get the gene from you. Okay, and then there's expressivity. Not everybody gets it. Although if you have BRCA, you have about an 80% chance of getting it. That's how high it is. But not all cancers are like that. And the other thing that people don't think about is that if, for instance, if you have BRCA, okay, just because you got breast cancer, since you carry that gene abnormality, you also have an increased risk of ovarian cancer. You also have an increased risk of not prostate. I don't think you could get prostate cancer, but you do have an increased risk of
Ovarian,
pancreatic.
maybe,
You have
okay.
and on the other hand, men have about a 6% chance of developing breast cancer. I've never seen one prostate and breast, but I've seen prostate and pancreas, for instance.
I've seen male breast cancer.
Have you?
Well, yeah, but have you
treated
seen
it.
it? Have you seen it with prostate though?
Ooh, no,
Like
not
both,
with
yeah.
at the same
Yeah.
time.
And that's interesting, because you're looking at extra male hormone, testosterone, and then extra female hormone, and that hormonal therapy, that's a whole nother thing. And I feel like years and years ago, that was such a big thing. And I think, not that we're getting away from it, but feel free to talk about hormonal testing, or not testing, treatment.
Hormonal treatment is the first stage.
Okay.
Okay, it's still, unfortunately, it's in a lot of, even on my own specialty, they just use hormonal treatment, and it's passé. It's almost malpractice to just use hormonal therapy. But now we're using a lot, when you have a genetic abnormality, we are using immunotherapies.
Right.
Okay.
Yes.
When you talked earlier about chemotherapy, I don't even give chemotherapy. No, that the medical oncologist does.
Okay.
But I do basically hormonal therapy, and I do treatment that works directly on the prostate cancer cell and does not allow that cancer cell to use male hormone, which feeds the cancer.
Right.
Okay.
Right.
Now, there are other medications that we can use, like BRCA1 and BRCA2, that actually are the cancer cell itself has the ability to keep the T cell from recognizing it, the white blood cell, if you want to call it that. Okay. And this medication interferes with that.
So if you don't mind explaining, how is the medication applied? I mean, is it surgically?
No.
Okay.
There are different ways.
Okay.
It can be intravenous, it can be oral. Okay. And it depends on the medication.
Okay. And give us some case studies of different types of treatments.
At least in prostate cancer, I don't know if you've heard of Lynparza. They put it on TV all the time. It's olaparib. Okay, that is one of the medications that I can use.
Okay.
For prostate cancer when it's advanced. I don't use that right away.
Okay.
Although if you have a genetic abnormality, you may use that first.
And what does that physiologically do once it's inside your body? What is it attacking in the prostate?
I believe it's a PD-1, PD-L1 inhibitor.
Okay.
And what it does is it just there's this mechanism that the cancer cells that keeps the if you can imagine, this is the cancer cell and this is the white blood cell. I'm going to call it white blood cell because it's easier that way. And this one is designed to eat the cancer.
Right.
But it has a pattern that it uses to recognize the cancer cell. okay, or a protein if you want to call it that.
Okay.
But the cancer cell makes another protein that blocks it.
Uh-huh.
Okay.
Right. Clever.
And so what these medications do is they keep this cancer cell from using that protein. And so the white blood cell can identify it and destroy it.
I remember somebody
That's
describing
very
that as
simplistic.
Pac-Man back in the
Yeah,
days.
yeah. It's
like
very
your white
simple.
cells
It's very
are Pac-Manning.
simplistic, but
Yeah.
a very simplistic way of explaining something that's
Mhm.
complicated.
But it's
So-
nice because you can put your head around it.
So have you seen, I have a good analogy for this. Have you
Tell
seen
me.
Star Trek before?
Oh, heck yeah.
So
yeah.
they have cloaking devices.
Yes.
So the cancer cells are able to basically cloak themselves from the immune system. And what these medications do is they get rid of the cloaking device so that your immune system can see the cancer cells and destroy them.
Okay.
So that's kind of the,
So that's kind of a Harry
Easy
Potter
way,
reference
yeah.
too, because Harry Potter's got the cloak.
there you
his,
go.
his
Yeah.
invisibility,
The invisibility cloak.
Yeah, so you
Exactly.
can't- no
Yes.
invisibility.
That's a good way to
cloak here.
explain it.
You
Yes.
can
Yeah.
detect it. Yeah.
And it's interesting too because cancer is so stinking smart, but we're trying to be smarter, and that's kind of where it comes in. Dr. Mendel, radiation oncology, I think especially with prostate cancer, there are and have been so many different ways to treat prostate cancer with radiation. I remember radiation seeds. I don't know if that's still a big thing or not, but I remember when that was first coming on the market, wrong word to say on the market, but we talked a lot about that, but it was a lot of excitement around it because then it was localized. That's why I was asking about surgery. You can put the seeds into the prostate itself. It was radiating in there, but just again, you're 12 years old. I get it. You're super young. But in your time of practicing, what have you seen as a standard of care with radiation? And then going into what's happening now, and this could be a whole show, but so we'll kind of go in and out.
If he's super young, he's a child genius. Okay.
He's like that doctor, is it Doogie Howser?
Yeah.
Yeah,
that's
you're
who
kinda
he-
like a
that's
Doogie
it.
Howser
He looks
guy.
just like him, doesn't he?
Yeah.
I
kinda
wonder how
does.
many years it's going to be for me to get my white hair.
It's, you
And
know
then you're
what?
gonna
It's a
be like,
blessing. It's a
You're,
blessing.
you've been here too long.
But you have the beard. You know, our prostate cancer, and you remember, so we had Dr.
My beard used to look like that 25
Yeah.
years ago.
Yeah, good job for wearing a beard. So on that note of from days of old to now, do you mind if when did you start practicing? And that way I can at least put a year in my head of when we started talking about things.
So basically, I started with Rio Grande Urology. So I
Okay.
started with them like about 2.5 years ago.
Okay,
And so
so
residencies.
you're 13, not 12.
Yes.
Okay. So I'm thinking seeds. So let's kind of start with seeds. Before it's seeds, then like seeds were a new thing. Talk about that, and then going into what you're doing now, what you're able to do now.
So we still do that.
Okay.
So it's called brachytherapy. So when we implant radioactive pieces of metal, that's brachytherapy, and that's low dose rate. So we leave the seeds in there, they emit radiation over time and decay. I don't do that as much because we have essentially a more efficient way of doing it, something called HDR, which is a different type of brachytherapy, high dose rate, where we use an afterloader. This is a machine that has an iridium source that comes out on a wire, and we implant catheters inside the prostate, and it delivers the radiation to the prostate from the inside out. And instead of leaving the radiation inside, we take all the catheters out and the patient goes home. So that's what we do now. And I prefer that method mostly because you can make up for if, say the catheter is too close to the urethra or something like that, you just don't use it. You can sculpt the radiation. And really what's become more popular now for radiation therapy is being more precise, number one. So our margins that we use, we do everything we can possibly to make sure that our margins are within a couple of millimeters of what we're treating. The HDR, we're actually boosting lesions. And so you put the catheters in, we have an MRI that we can see the lesion, and we boost that area to higher doses because we know where the cancer is. And we've actually started doing that with external beam treatments as well, where we know where the cancer is. So 5 years ago, people would just treat the whole prostate at the same dose, right?
Right.
You have your prostate, the cancer's in there somewhere, you treat the whole thing, that's it. Now we're a little bit more smart. We're more targeted. We know where the cancer is, so why not give it more dose in that area?
Right.
And you can even limit dose to some of the other areas that you don't, necessarily need to treat. And so that's been the name of the game now.
Okay.
And I think if you looked back, kind of like even when I've been practicing, so my residency is 5 years. I've been here 2.5 years. When I first started, in residency, I still remember patients were having a lot of rectal toxicity and bladder symptoms and things like that. We've now shrunk the fields, and we put devices like the SpaceOAR device. We talked about it last time, but it's basically a gel between the prostate and the rectum.
I remember that.
And I hardly
it's
ever...
like a protective gel, right?
Exactly.
Okay.
And I hardly have patients complaining of rectal symptoms now.
Huh.
So
So is that a standard of treatment now? That gel just
I put it in
there
everyone I
just no
can,
matter
yeah.
what?
Every single person I can, I'll put that in because I think it helps.
Right.
And it doesn't stay there permanently. You just put it in and it goes away after four to 6 months, something like that.
So the body dissipates, it's on its own?
Yeah, it's mostly made of water, actually. So, but anyways, I think that just like, prostate cancer in general, everything's evolving rapidly. Radiation oncology as a field every 5 years it's totally different. So like things we were doing 5 years ago, some of them we don't do now.
Right.
But at our center, we basically I treat everything. Any patient that comes, male, female, brain cancer, gynecologic cancer, prostate cancer, we treat all of them. And we have all the treatments that you can get at most places. That was the whole goal for me coming back, was to bring everything that you can get at a university and do it here. And so
thank you for that.
Yeah.
I mean, really, I say that. Again, I talked about my mother. My mother died 29 years ago, and she had small cell lung cancer that went to the brain. Gamma knife was relatively new at that time. I think gamma knife was introduced 31-ish years ago. We didn't have one in El Paso at the time. We had just gotten one. And I remember Dr. Gupta years ago was talking about that. But I'm thinking at that time, it was such a brand new thing. But when I look at it now, the targeting of the 30-year-old gamma knife compared to now, I know that's not prostate related, but just in general, is that something that's still used? And maybe I'm just a smidge about that. I know it's not prostate, but it's still fascinating because it's radiation oncology.
Absolutely. Yeah, I trained on the gamma knife in Dallas, and we unbelievable amounts of treatments. And it's probably the most precise, to be quite honest.
Okay.
Yeah, I mean, the thing is with gamma knife, they actually bolt a frame to your head so you can't move. And you are treating brain tumors or brain metastasis. Usually that's what we're using the gamma knife for. Or like an acoustic neuroma or something like that. But it's very precise on the order of like less than a millimeter. And so the problem is you can only do that in the brain, right?
Exactly.
So and there's some kind of technical issues. It also takes quite a while sometimes to treat on the gamma knife because it's not a linear accelerator. It actually has cobalt sources in there that are all focused on one area. And that's how the doses are so high.
Okay.
And when you do the treatments, they're called shots. So you kind of move the patient into the area where the radiation's converging.
Okay.
And it's kind of the simplistic way of thinking about gamma knife. But I think it's used a lot. We used it a massive amount in Dallas. I know they still are. They have dual bunkers now where they have 2 Icon machines, and they're just treating patients with the neurosurgeons there. And they have one here at Sierra Providence that's, I'm pretty sure, is pretty busy.
I just remember the blood-brain barrier, and chemo wouldn't pass that, and it was crazy. So Dr. Vogelweed, I'd like to go back to different types of treatments. I know we're talking a lot about radiation. You were talking about hormonal treatments like the first line of defense. But as a surgeon, let's talk about surgery, prostate cancer surgery. When do you do surgery? When do you opt not to do surgery? Again, when I shouldn't keep calling it the old days, but I do. But I always think of prostate cancer, prostate surgery removal. If not, is it always that the entire prostate's removed?
Yes.
And then from there, usually radiation. And again, that's old days. How has that evolved, or is that still kind of the same?
Well, both are used.
Okay.
They're both used, and they're used frequently, and probably they're both just as effective. Okay. The differences are age. Okay. But generally speaking, you're looking for a cure when you're operating on the prostate. The same way you're looking for a cure when you radiate the prostate.
Right.
I can tell you that radiation oncologists have slightly different criteria than the urologists do as far as that is concerned, because we both think that we're best at curing the disease.
Of course.
Okay. And we both are very good at curing the disease, but nobody's perfect. Surgery is usually used more in a younger person. Okay, if you have a 50-year-old or 55-year-old or even, the limit is usually around 70.
Okay.
Of course, if you have a 65-year-old that's a diabetic and has had an amputation, he's not going to benefit from surgery because he's not going to live that long. But generally speaking, if it's younger, healthier male, we'll opt to operate. Of course, it's always the patient's preference. And we do like them to get the medical oncologist's opinion too. And but if it's an older patient, well, then the urologist will probably say, well, he's going to take care of it. He's going to cure it better than we can.
Right.
He probably is. But
I feel like
that's
prostate cancer is that cancer that you have so many differing opinions on treatments. Is it the most differing opinion of all the cancers for treatment options? I feel like
wouldn't
that's
think
always
so.
been the mantra. It's like, look at everything, go talk to your doctors and really come up with an answer altogether.
Do you know any particular field in medicine where every single doctor agrees with every other doctor?
Excellent point. Absolutely
Okay.
not. No.
There is, and it may be, and I was just, he was talking about pathologists. Pathologists do a good job, okay?
Yeah.
It's the complicated cases where you need, you need more studies, you need more stainings, you need more whatever it is that they do. But, they're the ones that look at it first.
Right.
And in this particular case, there are, I may say that I'm better at it. If I have a 70-year-old that's in good health, if he goes for radiation, he'll probably do just as well as he did if I operate on him. Okay. And then the other thing is, if I operate on one and it doesn't work, if he has positive margins, if he has local disease that came back, he's the one that's going to take care of it.
Right.
You're
now he, not Dr. Mendel.
Well,
That guy over there.
I'm sorry.
I'm the only one there. So.
Yeah.
Well, he's too young.
come to see me.
I forget.
Exactly.
But on the other hand, the patient may opt primarily, and he may be a 60-year-old that opts primarily to have radiation, and then disease comes back. If it's localized, you can still come back and take out that prostate. Of course, that's a lot harder to do.
Right.
And it's fraught with more complications, but it's doable. And if you have a physician that does that a lot, then they can probably do okay.
Right.
It just makes it a little bit more complicated. But the two, that we complement each other is the best way to put it.
Oh, without question. Yeah. I feel like it's always a team approach.
I think it's kind of changed a little bit. Nowadays, when patients come to my clinic, the way we operate, the patients get all the options. And I think prostate cancer is probably the disease site that has the most options. I mean, you could talk to the patient for 2 hours about their treatments. And so when they come see me, so the way it works at our clinics, there would be a primary urologist who diagnoses the cancer the majority of the time. And they're going to send that patient, usually if they're 50, 60, or 70, they're going to send them both to a surgeon and to me.
Okay.
And so we can both go over the options and explain to the patient kind of, what's going on, why is this happening, what are we going to do? And it allows the patient to have an informed decision. And it's very complicated,
Yes.
And it's not just, this is the best treatment for you. And I always tell the patients I'm very biased.
Yeah.
Because of course I think radiation's great.
Right.
Well, Dr. Vogelweed always tells me,
Of course
Travis
surgery's
cures everything.
Yeah.
Yeah. So
Dr.
it's
Mendel.
overwhelming.
yeah, radiation cures everything. Yeah. So I tell them that, hey, I'm very biased and I honestly just want what's best for you.
Yeah.
And sometimes the patients, they don't want to get cut on. And so they want to get surgery. And these are even young guys. And I even tell them, if I was 50, I'd probably do surgery personally.
Yeah.
But a lot of this is very personal. And so the patients, they have to understand what's going on in order to make that decision, because it's more of a personal decision for the patients, because they're going to have to deal with the
And
complications.
does it become
with the
overwhelming
treatments.
then for the patient because they're the ones that have to make the decision on the treatment? Whereas other treatments, it's like the doctor says, you need to do A. There's not a B, C, and D here. You need to do A. Is that something that you all run into I remember we had one show, we had a prostate cancer survivor on, and he said that was, the overwhelmingness that he had all these options in front of him and didn't know which one to choose. And he kept saying, what's the best option? But again, there's all these options.
So that's where the physician comes in. So you give them the
Exactly.
options, and then you meet the patient, you understand their personality, and you help guide them, And they'll sometimes be very passionate about one way or the other, which is fine. But if it's a patient that's like, doc, what would you do?
Right.
And you can give them your honest, like, pretend I'm your father. What would you do? Then you can give them I give them my honest opinion on what I would do.
Right.
But really, like, after you talk to the patient for, 15, 20 minutes, you know their personality and you know kind of what's going to be a good fit for them. And so that's how I feel when I'm speaking with patients. I'm just trying to guide them in the right direction, more so for a treatment that would kind of fit their personality or fit kind of what I understand about them. Exactly.
Yeah. Okay.
Ultimately, the patient's the one that's going to decide what he wants.
Right.
And we really don't want to tell them what to do. We want them to get a good idea, a good understanding. And yes, it happens just as it happens to them, it happens to me. Doc, what would you do under these circumstances? And there are times when I say 50-50.
Yeah.
50-50. I think either choice is good for you.
Yeah.
And ultimately, but I will not pick for them. Because if you pick for them, then it's your fault.
I get it. I
And-
respect
and-
it
and you-
very much.
And that happens.
I think that's the beauty of our group, though. So our group, this is kind of a shout out to Jeff Spear. He's like my big brother, right?
Way to
So,
go, Jeff Spear.
I mean, I still remember the
current
first time
president
I
of the El
met
Paso
him.
County Medical Society.
Yeah, he's an amazing guy.
Yeah.
But I still remember sitting down in his office and talking about these different ideas that I had when I started, because there's a way, there's a business side of medicine as well.
Right.
And so it's very rare to be in a situation where you can sit down and make the best decision for the patient. And I still remember vividly in his office, because I was just starting, I was really nervous, and I was kind of like shaking things up. And I remember Spear like looked me right in the eyes and he said, "You just do the right thing for the patient and good things will happen."
Oh.
And that's it. And that's how we work.
Right.
That's how the group works.
Right.
And so, and I know that every clinician is thinking that way. They're trying to be the patient advocate, even in times when the insurance is giving you a hard time. And,
Right.
It's just, we're constantly trying to help. And that's like what I love the most about our group is the whole group is like that.
Yeah.
They just, everyone's from here. This is our hometown.
These are our people.
These are our people. Yeah.
Right.
And we're trying our best to take care of them.
Right.
And so I think that's kind of like the magic of our group right now.
I
But
love that.
I know Vogel deals with the same.
But I'm
Not
not. I'm not
stuff.
from here.
You
But
are
you've been
now.
here long enough. We've
40
assimilated
years.
you.
That works.
Well, that works. Yeah.
That works.
No, but if you're a true physician, do not do harm.
Right.
You try
Right.
to help your patients,
Yeah.
and we do it to the best of our abilities. I mean, if a patient asks me, "Can you guarantee that this will work?"
Oh, that's a
I
terrible word.
have a very simple answer for them.
No.
I said I can't guarantee that it'll work, but I guarantee that I will do my best to see that it works,
Right.
which is different.
Exactly.
And I live by that rule.
Yeah.
You do the best you can for your patient, but you're just as human as they are.
Right.
I always say there's no guarantees in life.
There's never a guarantee in life. Wouldn't
Yes,
it be
there
nice
is.
if there was?
It's called
You know,
taxes and
That's
death.
it. Yeah, taxes and
And cancer
death.
growing.
And a couple.
Cancer
Stop.
growing.
But I kind of on that note too. So if there is, say somebody has gone through genetic testing and they are now not genomic tests, but genetic testing. So they are somewhat predisposed because they do have some genes in there that would make them more apt to get cancer. And I'm saying cancer in all. In specific matters though, for prostate cancer, if you have this gene, is there anything that you can do in your lifestyle that can help prevent it? Now that you kind of have this little spot in your head going, I have maybe a predisposition. Is there anything that you can do to kind of ward that away? Obviously get checked all the time, but
Any person that has cancer of any kind can benefit for improving their lifestyle, which includes exercise and diet. They do better. Prostate cancer patients that lose weight, do exercise, control their diabetes, control their high blood pressure, they live longer and they respond longer.
right.
Okay, there's no question about that. But if I were to tell my patient, if you change your lifestyle, this will keep you from getting the cancer, no,
Right.
that isn't going to happen. What you do, it depends on the type of cancer, but what you do is you tell them, this is the genetic abnormality that you have. And I'm not a genetic counselor, but most of these people that do the genetic testing have counselors that work for them.
Mm-hmm.
And the patient can get in touch with them and get counseling on
Oh, I didn't
how to
realize
take care
that.
of, how to take, how to approach the genetic
Expand on
abnormality.
That's actually a really good point. So the counselors would then, if you contact the counselor, would kind of give them an idea of, okay, you are positive for A, B, C, and D.
And these are
and
your
then
risks.
let them kind of know what, yeah, because I would get the test and have no idea how to read it. So
Well, I
someone's
mean,
gonna
it's
help
even hard for
explain
us
it.
to read it,
Okay.
okay? Because there's hundreds of genes, hundreds and hundreds of genes. And, we're still, when you're talking about early, we're still in our diapers, or maybe we're still in utero as far as understanding genetics.
Mm-hmm.
It's very, very complicated. These few tests that we found that are associated, in prostate cancer, if you, theoretically, if you have advanced prostate cancer, you have about a 12% chance of having some kind of a genetic abnormality. And I haven't even gone into one part of that, but you have about
That's
a
a whole
12%.
show. Right, okay. Mhm.
But in my own personal practice, I haven't seen that.
Okay,
My,
interesting.
my percentage is much lower.
Okay,
Okay. The other part that I didn't go into is just because you have just because you do not have an inheritable disease,
mm-hmm.
the cancer itself from the prostate can undergo a genetic transformation, if you want to call it that, or a genetic alteration. And that genetic alteration may be something that is a BRCA abnormality, for instance, or an ATM abnormality. And that's helpful to the patient because it may help you as far as how you're going to treat him. So you
So if I'm
cannot have an
understanding-
inheritable disease. In
Okay.
other words, if you do not have, you have breast cancer and,
Right.
and you do not have an inheritable disease, but they test the tumor itself, and they do a lot more of this than breast cancer, and they test the tumor itself, and they notice that the alteration in the primary is different than what your genetic testing shows.
Interesting. I didn't
And
realize it could
that
be
does
separate.
happen.
Huh.
I have a couple of patients where I've tested the
So it's
tumor.
not often, but it does happen.
It can happen, yes.
And so your treatment then might be a little bit different.
It may help you.
depending
It may
on-
help you with your treatment, yes.
Interesting. Okay.
Just to make it more confusing.
No, that's good though, because we have some breast cancer shows coming up. So that'd be a really nice
I'm
targeted
not.
question.
I'm
know-
talking about prostate. Okay.
I get it. But I'm just thinking, there's just a lot of genetic testing in breast cancer is
For
what
sure.
my thought process is on that. But what we haven't really hit on yet is, and we have like 15 minutes before the show runs out, I would love to talk about staging, not like spend too much time on it, but as the person who usually finds the prostate being in trouble, and then maybe, PSAs, DRE, we have to do a biopsy now. So maybe talk about biopsying, how that's done, and then staging if there is a positive cancer diagnosis.
Well, the biopsy, the traditional way is transrectal. You put an ultrasound probe in the rectum, and there's a needle goes alongside it, and there's a gun that fires.
Mm-hmm.
And you do
Don't say a gun that fires in a medical show.
okay.
Goodness.
A gun that snaps.
There's a needle that very gently, once upon you making that area numb. Sorry, I'm messing with you. But yes, a gun that fires because it gets a specific
Yeah,
piece of tissue.
I don't even know how else to describe it. It
Yeah.
snaps, but that doesn't really describe.
Right.
And the other one, actually, it's a needle that goes out and comes back in, and it cuts a piece of tissue.
Mm-hmm.
True cut is a term that they use.
Mm-hmm.
But you get that the traditional way is to do 12 biopsies. It used to be 6, it used to be 3, but now it's 12, and then we started getting into MRIs. And if your MRI identifies a focus, you may just decide to biopsy that focus and biopsy nowhere else, or you may do 2 or 3 biopsies of that focus and biopsy everywhere else. That's a personal preference.
Mm-hmm.
And there's a little bit of controversy as far as that's concerned because they say that only the only ones that show up on an MRI are the high-grade tumors. And if you have a low-grade tumor,
won't
probably
show.
doesn't need any treatment. Of course, when you treat it, I'm sure that he's going to treat the whole prostate, but with different amounts of radiation. But once you've got the diagnosis, you have to take in consideration how bad the cancer is. That's called the Gleason score, or they use a grade grouping now. You have to decide, you have to check and see whether that cancer is spread. So you're going to do, we used to do a CT scan and a bone scan, which is still considered at a certain point a standard of care, but there's better testing nowadays. Now we have a Polarify scan, a PSMA scan. These are both of them are, these are PET scans.
Okay.
And PSMA stands prostate-specific membrane antigen. And so these can actually go directly and sit on the prostate cancer cell.
Oh my goodness.
And identify it, okay?
Okay.
And so if you do a PSMA scan, it's much more accurate than a bone scan and a CT scan for metastatic disease. It also can tell you whether you could do just a PET scan, and it can tell you whether you have extra prostatic extension. Or even if it doesn't, a PET scan may. Not a PET scan, PET scan, a PET CT.
I forgot what PET stands for. I know PET scan.
Positron emission tomography. Yeah.
Say it slowly.
Positron emission tomography.
Positron.
Yeah.
Okay.
But so the staging is fascinating for prostate cancer. So I've really gotten into biopsies more recently because I do targeted biopsies.
Okay.
Based off the MRI and actually now based off the PSMA scans. So I have a couple of stories for you.
Okay.
I haven't told you this one, so you're going to love it. But anyways, for prostate cancer staging, it's basically just you use your finger. And that's how they're staging patients. You feel for a nodule, and that's, you decide, like the whole prostate's hard, half the prostate's hard. I mean, there's a nodule, and that's your staging.
And have we said the size of a prostate? It's like the size of a walnut, right?
It varies, and as you get older, it gets larger.
Okay.
Right.
Okay.
And so we've talked about the BPH and things like that on other episodes of this.
Okay.
But I think that nowadays we're imaging's becoming much more in vogue, and I think it's a little bit more accurate. And what we're doing, back in the day, they would do a digital rectal exam, then they do a biopsy, and it would just be a random biopsy at the back of the prostate. The cancer isn't always in the back of the prostate, and that's where the MRIs come in. So you can see the lesions. It can be in the back. It's probably like 80% of the time it can be in what's called the peripheral zone. But anterior in front of the prostate, about 20% of the time you can find cancers there. And that's where it's kind of this area has exploded, where we're using now MRIs and template biopsies. And so you'll get your template biopsy, you'll probably get an MRI before or after.
So the template biopsy would be what then?
A random biopsy of the prostate.
Okay.
Like a systematic
Okay.
biopsy of the prostate. But now you get more information up front or even after that, your PSA is high, maybe we missed it. So you get an MRI, there's a lesion in front, and then those patients usually come to me. And I go in and I target those areas and take pieces of that to see what kind of, if they have prostate cancer, what kind of prostate cancer. And so that's really exploded. And the story that I have for you, so we have a patient who had a rising PSA that started back in 10 years ago, okay? He had a biopsy, it was a random template biopsy, and he had a small percentage of one core Gleason 6.
Yeah.
So it was like 1%, like a little speck of cancer. And so everyone just says, we'll watch it, all right? So his PSA keeps going up. He gets biopsies. He goes to MD Anderson. He goes to Mayo. They get MRIs, they do targeted biopsies, they do all these things. Nothing. No cancer diagnosis.
Oh my goodness.
So he comes to me, his PSA is 40, which is extremely high. And we get a PSMA, and there's a lesion in the front that's have it on the PSMA scan. So I go in there and I biopsy, and we diagnose him, and now he's going to get treated.
So
fortunately, he wasn't
PSMA,
metastatic after all this.
It was not.
No.
After a score of 40.
After over a decade. It was unbelievable.
So he's gone back and forth testing.
But prostate
well.
cancer is weird that way. You can have somebody who has a high-grade cancer, and they last a long time, and who knows why. And you have these low-grade cancers that you figure they're going to live forever. Most of your Gleason, 6s, which is, they don't even need treatment. If it's truly a Gleason 6. And that's the problem, is that, 10 years ago, I mean, when I first started doing biopsies, I would wear a glove, stick my finger in the rectum, and then I'd slide a needle on top of my finger And there have been urologists that took pieces of the needles when they, pieces of their finger
Oh, I'm
when they do
sure.
biopsies.
Yeah.
And then you felt for that nodule. That's the only way you could diagnose it.
Wow. Goodness
And then
gracious.
you sort of aim for it, and you
and you hope you get it.
and you hope you get it.
Wow.
See, that's like unfathomable to me. I can't even imagine doing that with one of those needles, because I'd be like, go right through my finger.
Well, it
you have
thankfully
to like have
it never
a steel,
happened.
steel
Never happened to
covering
me.
on the finger and then going in. But yeah,
I went through my glove one time, but didn't do my finger.
jeez.
But
it
then-
just goes to show how much things have changed.
Oh,
we
yes.
we have
know?
more information now, and we're still learning how to use that information. That's the exciting part.
Yeah.
So we now, patients get a PSMA scan, especially if they have higher risk cancer. We can see where the cancer is, and that changes our treatment a lot of times. And so, at diagnosis now and after diagnosis, this information is very important. And so now we have it.
Right.
And we're still learning what to do with it and
You
how
guys
it's
are
gonna
so
change.
excited. It's really cute.
Yeah.
Yeah.
It's a very
Well-
exciting time. Yeah.
You should ask them about oligometastatic disease just to make it more confusing.
Okay, you know what? We can, but we have 7 minutes before the show ends. But let's talk about it a little bit, because this is the fun stuff. This is the new stuff that I like talking a little bit about.
So oligo means few. All right. So
Okay.
you have metastatic cancer. Some patients, we always thought of metastatic cancer as you're metastatic, you're stage 4. But there's a spectrum of metastatic cancer. And where a lot of practitioners are thinking that if you're able to identify patients who have smaller amounts of cancer, 1 or 2 lesions up to 5, there's varying different definitions, that those patients are still curable, because they're still, the easy way to think about it is if you had a cancer, say 5 cells snuck out, okay? They snuck out, they started growing somewhere. But only those cells left, right?
Right.
So you treat where the cancer started, and then you treat those other sites, and the goal is to cure the patient. In reality, Fogleweed always reminds me, the chance of curing those patients is extremely low.
Right.
Probably less than 30%.
I've heard you're not allowed to say the word cure when it comes to cancer. But yeah.
But even if you
different.
don't cure them, if you give them more time,
Oh, goodness.
Exactly.
that's
Yeah.
the important, and you can,
Yeah.
and you do.
So
And
when you're looking at targeting these like 5 cells that you said, 5 cancer cells that are gone now and maybe have grown a little bit. So this is a therapy that can find those cells?
Yeah, so there's varying things. One, if you get a PET scan, they light up like a light bulb on a
Wow.
Christmas tree, and you can see exactly where they are, and you target them. And that's what I do with the radiation. So I'll treat the cancer where the primary started, and then I'll find these lesions and I'll treat those in very few fractions with ablative doses of radiation. Very focused. There is a new product on the market, which is, the Pluvicto, which is coming down.
which is a lutetium PSMA scan. The PSMA is, as I said before, is prostate-specific membrane antigen. It's an antigen that goes and fixes on the prostate membrane of prostate cancer cells. Okay, and it's an isotope that helps identify it. But the lutetium is an isotope that actually emits radiation, and so if you check with the PSMA to see if they're PSMA positive, then you give them Pluvicto, and so that will
What's
take.
Pluvicto? Sorry.
That's the lutetium.
Okay, gotcha.
That's
It's just
okay.
a radioactive.
It's a radioactive isotope,
targeting, yeah.
and it actually goes and treats that target with radiation.
Gotcha. Wow.
And
okay.
It's one of the new, just approved treatments that we have, for advanced prostate cancer.
It's very exciting. So imagine, just imagine this. You can get a scan that shows exactly what targets your type of cancer, and then you just target it with a radioactive element, and then it goes to the cancer, gets rid of it.
That almost seems fairy tale-y to me
It's-
in a beautiful way,
it's the way it
because
works,
isn't that
yeah.
the hope that everyone has
So that's
if they have whatever their cancer is?
You usually don't cure these patients, right? You're decreasing the bulk of disease, and the way that the Pluvicto works is, we're never going to cure it, But I think that it's another therapy that's more targeted, and it's this new field is called theragnostics, and basically you're able to figure out what the cells have on them, and so you can target them with whatever therapy is related to that target.
Right.
And so it's going to explode probably. It is.
But one of the things that you have to consider is that not everybody is PSMA positive. Okay.
Yeah.
Yeah,
Not
okay.
that that's, yeah.
And
but good point. It's an excellent point.
I always tell my patients when they come to see me, prostate cancer smells. It does. Prostate cancer cells are extremely smart.
Yeah.
They can fight anything you throw at them, anything.
Mm.
And the goal with treatment is not cure. The goal with treatment is to extend.
Right.
And if you can extend life and you can extend quality of life, if somebody presents with metastatic disease 15, 20 years ago, I mean, cancer's out of the bag, he's got it in the bones.
Exactly.
Survival is about 1.5 years with treatment.
And we're talking about these 5 cells that you're talking about now that now you
No,
can
we're
target
talking
them.
about somebody shows up in your office for the first time and they got cancer of the prostate that's already spread.
I see.
Okay.
Yes.
With hormonal therapy, which was the standard of care since 1942, the survival is about 1.5 years to 2 years.
Mm-hmm.
Okay. Nowadays, it is rare that you don't get 3 to 4 to 5 to 6 years.
Wow. Nice.
It depends.
Yeah.
Not every, just as I say, not all cancers act the same.
Right.
Not all cancers respond the same.
Mm-hmm.
And it's, to me, it's disillusioning when I have to tell the patient, I don't have anything else to offer you.
Mm.
Okay.
Mm-hmm.
And this happens a lot, particularly if you have somebody's 80 or 85 years of age or 90
Right.
years of age.
Right.
I have several patients that are in their 90s. They're not going to handle chemotherapy.
Yeah.
They're not going to want chemotherapy, even though the initial chemotherapy for prostate cancer, relatively speaking, is very tolerable.
Mm-hmm.
Okay.
Mm-hmm.
But it is that's where it becomes hard. But personally, I tell them up front, I say, listen, I can't cure you.
Mm.
My job is to give you more time and give you quality time.
And
I
that's a
may or
lot
may
to
not be able
swallow.
to do it,
Right.
but
Right.
you have, my feeling is that you have to tell them up front.
Absolutely.
I
Absolutely.
can't-
I'm
I
in full
can't-
agreement with that.
and-
Yeah.
And you even, and I'm sure you may get this too. I get patients' family comes in, please don't tell them.
Oh no,
Please
I
don't tell 'em.
agree with that at all.
Okay.
Yeah.
And you have to tell them.
Right.
Your obligation is not to the family, it's to the patient.
Right. Always. And I like the Jeffrey Spear, way to go. Do what's in the best of the patient.
Yeah.
That's
Do what's
absolutely
right
it.
for the patient and good things will come.
You guys,
That
thanks
was
so
his
much
quote,
for
yeah.
being here. I know this is an underwritten by Rio Grande Urology and Rio Grande Cancer Specialists. We've had with us this evening Daniel Vogelweed and Travis Mendel. And if you have not been able to catch this entire program, you can catch it again on pbselpaso.org. You can just go to watch, find the El Paso Physician program on there. You can also do it with the El Paso County Medical Society website, epcms.com, and also on YouTube. This has been a great program. Thanks both of you guys for being here. I feel like we can talk for another 50 minutes on this. I'm Catherine Berg, and you've been watching the El Paso Physician.